I'm Camille Kotton, and I work at Massachusetts General Hospital. It's a pleasure to be with you today to talk about vaccination in immunocompromised patients, how to optimize protection. As you can see, I have a few disclosures in the area of COVID-19, nothing pertinent to this talk. And today I will talk about immunocompromised patients being at much higher risk for COVID-19 even after vaccination. So we'll talk about how to optimize their vaccination approach, use of monoclonal antibodies to provide additional protection, and that testing, unfortunately, has not provided mechanisms to document who is protected and who is not, and then thoughts on upcoming variants that may require additional focus. So if we look at the CDC guidelines as far as who is moderately or severely immunocompromised, and this basically is a focus on who is less likely to respond to vaccination. That includes those receiving active cancer treatment for tumors or cancers of the blood, those who've undergone treatment with CAR T-cell therapy or received a stem cell therapy within the past 2 years, those who've received organ transplants and are taking medications to suppress the immune system, as well as those with moderate or severe primary immunodeficiency, advanced or untreated HIV infection, but not the majority of HIV positive people that we see these days, and then those on active treatment with high-dose steroids or other drugs that may suppress their immune response. And that last one can be a bit of a catch-all, includes many people on biologics and whatnot, but those who would be significantly immunocompromised. There was a nice paper just published that looked at a cohort of over 600,000 patients at academic medical centers across the United States who'd received at least 1 dose of vaccine. So this is kind of earlier on with vaccination. And you can see that as far as breakthrough infection, solid organ transplant were most likely to have breakthrough, as you can see here, compared to the lowest line is patients without immune dysfunction. And sort of somewhere here in the middle is people who've had bone marrow transplants, who have MS, who are HIV positive or have rheumatoid arthritis. So really solid organ transplant leads the pack as far as less protection from vaccination. But again, this was early on. And then if we look at this, this is interesting in that it provides information as far as who is succumbing to infection. And at this point, as of April 2022, it's really people who are 75 and up, primarily, who are dying. There are still people 50 to 74 and under the age of 50, and some of those may be immunocompromised, but I'm always impressed by the effect of age on on risk of breakthrough infection. Another way to look at this would be who has died, and predominantly it's unvaccinated elderly, followed by vaccinated elderly and even boosted elderly. And you can see the non-elderly, elderly is those 65 and up, non-elderly, boosted, vaccinated, and even the unvaccinated are a smaller proportion. But I think the effective age is pretty dramatic here. And then in another paper that I thought really made me think long and hard about how vulnerable this population is as far as post-acute sequelae of COVID, or what we call long COVID after breakthrough infection. You can see here in blue for the immunocompromised compared with red, non-immunocompromised, that for all of the post-acute sequelae listed here on the left, and this is immunocompromised as per the CDC definition, all of these convey a higher risk of post-acute sequelae in the immunocompromised. So not only are they at higher risk for breakthrough infection, they're at higher risk for many aspects of post-acute sequelae or long COVID, which is especially tragic. So in response to this, the Center for Disease Control recently recommended a 5th dose of mRNA vaccine for people who are immunocompromised. And so as of August, and I sit on the advisory committee on immunization practice for the Centers for Disease Control. As of last August, we recommended 3 doses as part of the primary series for immunocompromised, followed by a 4th or booster dose at least 3 months later, and now a 5th dose at least 4 months after that first booster dose. So all in all, 5 doses. I call this the 3+1+1. For people that had the Janssen vaccine, there was a different schema. It is a total of 4 doses that are recommended, and we do recommend mRNA vaccine over the Janssen vaccine. So who should get that second booster? Well, it's people with certain underlying medical conditions that increase the risk of severe COVID, people who are living with someone who is immunocompromised or at higher risk or not yet vaccinated due to age or contraindication. Those who are at higher risk for exposure, either by occupation, institution, or other activities, or for people who are living and working in an area where the COVID-19 community level is medium or high, which at this point, as of the end of May 2022, represents numerous locations in the United States. So who should wait on getting a second booster dose? Well, one of the few things the CDC says is that if there was recent infection within the past 3 months, but we're not sure how much that applies to immunocompromised. So I am recommending that people get booster doses rather than necessarily waiting the full 3 months. And something important that came out from the CDC discussions is that repeat boosting does not diminish subsequent response of the immune system with mRNA vaccines, and that's important. Other things that the CDC has said that on a case-by-case basis, providers caring for moderately or severely immunocompromised patients may administer mRNA COVID-19 vaccines outside of the FDA and CDC dosing intervals based on clinical judgment. So it does allow for flexibility. Obviously, many of you are in different countries throughout the world, so this may or may not be applicable in your region, but it has been very helpful for me in providing additional flexibility, especially if people got a vaccine, say, in the midst of very potent immune suppression or other times when they were less likely to respond. There's also additional guidance on revaccination, and that's revaccination is repeating at least 1 or more doses of vaccine. We generally recommend this be with an mRNA vaccine. And for people who've had ablation of their immune system, either through stem cell transplant or CAR T cell therapy, they should receive 1 or more doses of COVID-19 vaccine who received vaccination prior to or during treatment should have all of those doses repeated afterwards. And in general, we recommend that that be restarted 3 or more months later. And importantly, a patient's clinical team is best positioned to determine the degree of immune compromise, need for vaccination, and appropriate timing of revaccination. Also, we had guidance on B-cell therapy, and basically for people who've gotten B-cell therapy, say as part of a chemotherapy regimen over a limited time period, we recommend that vaccination be restarted about 6 months after completion of the B-cell therapy when they're more likely to have an immune response. And I'll talk more about a monoclonal antibody that could be used as a bridge to provide protection in the meantime. And for people who get B-cell depleting therapies on a continuing basis for rheumatoid arthritis, multiple sclerosis, others, COVID-19 vaccine should be administered approximately 4 weeks before the next scheduled therapy. So for some, that's every 6 months that they get a dose. So it would be 4 weeks before the next dose. And many have asked questions about antibody and cellular testing, and this is still not recommended at this time outside of a research project. We don't know the protective thresholds or how much antibody or cellular immune response is necessary for protection. We can't tell what is safe. And we do recommend giving vaccines and protective antibodies as recommended, not based on testing results. And, unfortunately, it doesn't seem likely that we're going to have the ability to accurately provide testing as far as who is fully protected anytime in the very near future. So it does seem like immunocompromised patients likely need more than vaccine. And in recent months, we've had the capacity to provide vaccine plus monoclonal antibody to provide better coverage, especially for high-risk patients. And the concept here is to do both antibody and vaccine. So vaccine triggers your own immune response, and then antibody provides immediate protection. There was a New England Journal publication on the use of tixagevimab with silgevimab, as you can see here, and the relative risk reduction in infection was about 77%. This was during a period of low disease activity, and it was before Omicron, so such as it is, nonetheless showed a good level of protection in unvaccinated people. So who is included in the emergency use authorization in the United States? You can see that it's many people who are, I previously mentioned, who are considered immunocompromised, and it is a pretty broad population. As far as prioritization, either due to shortage of monoclonal antibody and or the ability to distribute this well, the NIH said that it was best if we focused on people receiving B-cell depleting therapies as listed there, people on Bruton tyrosine kinase inhibitors, CAR T-cell recipients, transplant recipients, lung transplant recipients, those within a year of solid organ transplant, or who are undergoing treatment for rejection or with severe combined immunodeficiencies or severe HIV. So for some of you, if you have limited supplies, that may be the population to focus on. And the overall efficacy of Evusheld looks to be good in sort of real life studies. This was just published, or sorry, it's in a med archive, so yet to be peer reviewed, but it was over 1,800 patients who were given Evusheld, and you can see that the hazard ratio of infection, hospitalization, and mortality is significantly reduced by at least a third, by at least 2/3, sorry, and especially hospitalization. So it really does look to be effective in people who were vaccinated and who got this and at high risk. We had similar data that came out from Mass General, my hospital, Massachusetts General Hospital, and transplant patients showing a similar level of protection. Now, unfortunately, with monoclonal antibodies, because they're designed for a specific target, when the variants happen, we can lose efficacy. And as you can see here, tixagevimab was very protective against Delta, but really does not protect well against BA1 and BA2. Silgevimab protects well against Delta and BA2, but not well against BA1. And then you can see the combination here, best against Delta, second best against BA2, and then not very well against BA1. Now, many of you have heard about BA4/5, which is being seen throughout much of the world, especially South Africa, Portugal, and a little bit in the United States. So it looks like silgevimab exhibits 30-fold higher resistance to BA4/5 compared to BA2, which is unfortunate. These are all in preprints, not yet peer-reviewed. Yes, similarly, that there's reduced neutralization by serum from either triple AstraZeneca or Pfizer vaccinated individuals compared to BA1 and 2. So overall, it does look like it's effective now against the widely circulating BA2, but less likely to be effective against BA4 and BA5. And that's due to the, overall a short therapeutic lifespan of monoclonal antibodies due to the emergence of variants with mutations in the spike protein. And then there was another report of 4 out of 29 immunocompromised who had breakthrough infection after 3 doses of vaccine plus Evusheld. And what I thought was interesting, they actually had high spike protein antibodies, low neutralization antibodies, but that just goes to show you that testing for antibodies doesn't really measure the level of protection. So unfortunately, at this point, vaccination it works somewhat to moderately to relatively well in immunocompromised. Adding in antibody is likely to also be additionally protective, but people really need to wear a mask and be careful about hand washing and crowds, et cetera. So many of the same rules still apply to the immunocompromised. I do want to add that for those who get Evusheld vaccination, Evusheld should be deferred for at least 2 weeks after vaccination. That's in the emergency use authorization, although it doesn't seem to be that it really alters the effect of vaccination, but nonetheless, because it's in the package emergency use authorization, we need to abide by that. So just two quick clinical vignettes. One was a 65-year-old professor diagnosed with Waldenstrom's macroglobulinemia in 2020, treated with plasmapheresis and then ibrutinib and maroxafor, which is a small molecule selective agent of the CXCR4 receptor, who was given 5 doses of Pfizer vaccine. He's in a clinical trial. No spike protein antibody response was seen, although they're not measuring the cellular immune response. He's been in complete isolation. He was hesitant to go for any type of infusion or injection. He's briefly hospitalized for an unrelated reason. So my recommendation was to give Evusheld prior to discharge to provide him with additional protection. The other one is a 72-year-old heart transplant recipient now, one and a half years after transplant, not vaccinated prior to transplant, which is really an amazing time because the pre-transplant vaccines work so much better. And he's on tacrolimus and mycophenolate mofetil and prednisone as per standard. They've had 4 doses of mRNA vaccine, 3+1. Absolute lymphocyte count is somewhat low at 800. No clinical COVID-19 infection. So she's asking, should she get a second booster now, and she's due for it, or should she get tixagevimab, silgevimab? And so my recommendation was to give booster followed by monoclonal antibody at least 2 weeks later. Vaccine provides broader and likely better protection than a monoclonal antibody is always the theme. So in summary, let's optimize vaccination and use prophylactic therapy whenever possible. Key to ensure that all vaccines are up to date. The vast majority of immunocompromised patients I see have not been fully vaccinated yet. I do recommend Evusheld for immunocompromised patients before being discharged from the hospital because of complications with distribution and being able to readily provide this in clinic. I think it's a really novel idea as a bridge between deep immune suppression and when folks are likely to have a more robust immune response. In other words, after stem cell transplant, CAR T cell therapy, et cetera, as like some level of protection before vaccine immunity can kick in. And then it is adjunctive protection to primary vaccination. So think of it as like a belt and suspenders. So 2 different ways to hold up your pants and then 2 different ways to prevent COVID-19. I do think we're going to need to reconsider monoclonal antibody efficacy with the looming BA4/5 on the horizon. So thanks very much for your attention and happy to have questions.